1, 2,
And maybe female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the phone.
It's
300 please.
I'll keep your card again.
Pulse check. No pulse.
no more pulse.
Yeah. Where the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Oh. Oh.
All right, guys, another side note for nifedipine, however you say it. I didn't know this until I started working in the ER, but not all antihypertensives are kind of created equal. When you get to the labetalol episode, if you listen to it, I will also have something to say there about that as well. But typically in the ER, your go-to meds are going for hypertensive purposes, you know. They're typically going to be like your ACE inhibitors, like lisinopril, or your ARBs, your angiotensin receptor blockers. And that's like valsartan, losartan, stuff like that. And then you kind of have like your beta blockers. Now, beta blockers, in my experience, yes, they are a medication for blood pressure management, but typically we use it in the ER and what I've seen in practice as a rate control drug. My entire time in nursing school, I was taught that beta blockers are that type of medication that once you take it, like it'll yank your blood pressure down like really fast. But from my experience, what I've seen is that you get like a minimum to moderate drop in blood pressure. I guess it's just depending on the dose and the person, but they typically use it as a rate control drug. Anyways, with nifedipine or nifedipine, or the trade name Procardia, a calcium channel blocker is an extremely potent blood pressure medication. It's kind of like your last line kind of medication for blood pressure management. So seeing this, you know, and I guess having like the experience that I have now, and then kind of looking back at it now, going back through school, like it's crazy to me to see like these pregnant women getting like these massive doses of nifedipine or nifedipine, Procardia. It's crazy to me. I understand you have to manage the blood pressure, and whenever we get to magnesium sulfate, I'll also have my own opinions about that as well. But if you don't know, now you know that your calcium channel blockers like nifedipine or nifedipine, they are very potent, very, very potent antihypertensive medications. So this is going to be a great episode for you to kind of listen to. That way you can kind of understand, because if you're going to be in nursing or paramedicine in any way, shape, or form, you're going to run across antihypertensives, and there's a good chance you're going to run across Procardia. All right, guys, here is the episode.
Imagine a patient panicking in their bathroom. Like they've just looked down into the toilet bowl and they are absolutely convinced they just passed their entire perfectly intact blood pressure pill right in their stool.
Oh, yeah. That is a classic scenario.
Right. Their heart starts racing. They think their digestive system is failing, or, you know, that they're about to suffer this massive spike in their blood pressure because the medication clearly didn't absorb.
And then they do the worst possible thing.
Exactly. They reach into the medicine cabinet, pull out that orange bottle and prepare to take another pill to make up for the one they think they lost. And that split-second decision taking a duplicate dose of a highly potent cardiovascular drug could literally send them into catastrophic, life-threatening shock.
Yeah, and stopping them from making that specific, really dangerous mistake relies entirely on a clinician understanding the microscopic engineering of how that single pill was manufactured.
Welcome to the Deep Dive. I'm your host, and I'm sitting here with our clinical expert. If you are sitting in that third chair in the room with us today, you likely have a massive nursing school pharmacology exam looming on the horizon.
Or maybe you're prepping for the NCLEX. Or perhaps you're just a practicing clinician wanting to bulletproof your daily practice.
We know the pressure you're under, we really do. Pharmacology can feel like trying to drink from a fire hose of raw, just completely disconnected data.
Right. You open a drug monograph, and it reads like a dictionary written by a robot.
Yeah, an unfeeling robot. It's just walls of text, endless lists of side effects, and all this biochemical jargon that seems designed to confuse you rather than actually educate you.
Which is why we have a very specific mission for our time together today. We are taking the dense, intimidating clinical profile of a foundational cardiovascular drug, nifedipine, and we're going to decode it.
We are definitely not going to read you a textbook. We're going to build a functional clinical understanding of this medication from the cellular level all the way up to complex patient management.
So we're applying the Pareto principle to your exam prep today, the 80-20 rule.
Right. We are going to ruthlessly extract the 20% of the material that's going to yield 80% of your overall understanding.
Focusing relentlessly on those nursing implications, the patient management scenarios, and the high-yield concepts that always show up on those brutal pharmacology exams.
Our goal is for you to understand the intricate why behind the drug, not just memorize the what. Because when you know the underlying physiological mechanics, rote memorization becomes totally obsolete.
Exactly. You can just intuitively predict how the drug is going to behave. You start to anticipate the side effects before they even happen.
And you understand why certain contraindications exist. You know exactly what to look for when you walk into a patient's room. So, okay, let's unpack this.
Let's do it.
Before we can safely hand a patient that little pill, we have to deeply understand what that specific chemical is doing inside their body at a cellular level, right? We need to visualize the microscopic battleground. That brings us to our first major concept, the mechanism of action. So what exactly is nifedipine?
Well, nifedipine serves as the prototype drug for a specific, highly influential class of medications known as the dihydropyridine calcium channel blockers. And every single word in that classification carries massive clinical weight.
Okay, so being the prototype, that means it's the original model, right? The foundational standard that all the other drugs in this family are measured against.
Spot on. Now, calcium channel blocker sounds incredibly self-explanatory on the surface, but the actual physiology happening at the cell membrane is really fascinating.
I always find it helpful to visualize these abstract microscopic processes. So picture the membrane of a smooth muscle cell. This membrane acts as a highly secure perimeter.
Like a wall.
Yeah, exactly, like a wall. And embedded within it are these very specific, highly selective pores, the calcium channels. I picture these channels as like exclusive VIP nightclubs.
I love that analogy.
Right. So extracellular calcium ions are constantly swarming the outside, trying to get inside the club to start a biological party.
And in the context of a smooth muscle cell, that party is a physical contraction.
Right. The influx of calcium is the spark that tells the actin and myosin filaments inside the cell to slide together and tighten.
That analogy holds up perfectly under physiological scrutiny, honestly. The influx of extracellular calcium is the absolute required trigger for the contractile process of smooth muscle. Without that calcium crossing the threshold of the membrane,
The muscle just can't tighten.
exactly, it remains in a completely relaxed state.
So nifedipine enters the bloodstream and approaches these cells. In our visualization, nifedipine is this massive, unmoving bouncer.
A very stubborn bouncer.
Very stubborn. The clinical literature states that nifedipine inhibits the influx of calcium by physically plugging the channel. It doesn't send like a chemical signal to turn the channel off.
No, it literally stands in the doorway of the nightclub, occupies the physical space, and says, nobody gets in.
It is a literal barricade. The extracellular calcium simply cannot cross those myocardial and vascular cell membranes because the physical pathway is obstructed by the drug molecule.
Which is such a clean mechanism, but it brings up a massive conceptual trap.
Oh, I see this constantly on nursing exams. If I am administering a drug that deliberately blocks calcium and I subsequently draw my patient's blood to run a basic metabolic panel.
Well, their lab results show low serum calcium levels.
Right. Shouldn't I be vigilantly monitoring them for signs of hypocalcemia like muscle twitching or facial spasms?
Exam writers use that exact logical leap to trick students all the time. But the answer is absolutely not.
Wait, really? None at all.
None. This is a critical foundational concept to lock away for your exams. Serum calcium levels remain entirely unchanged during nifedipine therapy.
It feels so counterintuitive at first glance. I mean, we are blocking calcium, yet the calcium levels don't drop.
The key is distinguishing between the movement of calcium and the total volume of calcium. We're only blocking the transmembrane influx at the site of specific smooth muscle cells.
Oh, I get it. We aren't chelating calcium. We aren't eliminating it through the kidneys.
Right, and we aren't pulling it out of the bloodstream. The calcium is still entirely present in the serum, circulating freely in the blood plasma. It just cannot gain entry into those specific targeted cells.
Returning to the nightclub analogy, the bouncer locked the front door of the building. The patrons are still out on the street in the exact same numbers.
They just aren't inside the lobby. So if you encounter an exam question presenting serum calcium monitoring as a primary nursing intervention for a patient on nifedipine, you can immediately identify it as a distractor.
That is such a good tip. Okay, let's dig into the ridiculously long prefix of that drug class you mentioned earlier. You called it a dihydropyridine calcium channel blocker.
Yeah, it's a mouthful.
The existence of that prefix implies there is a whole separate category of non-dihydropyridines out there in the pharmacy. Why does this structural difference matter to a nurse standing at the bedside?
Because the distinction between dihydropyridines and non-dihydropyridines dictates entirely different clinical applications. The two major non-dihydropyridine calcium channel blockers you'll encounter are verapamil and diltiazem.
Okay, verapamil and diltiazem.
And those drugs exert what we call balanced effects. They block calcium channels in the sinoatrial node, the SA node, which is the heart's natural pacemaker, and the atrioventricular AV node, which is the electrical relay station. Plus, they block channels in the vasculature.
So they are multi-tool drugs. They suppress the electrical conduction system to slow down the heart rate, and they simultaneously dilate blood vessels. They impact the heart's rhythm and the body's plumbing at the exact same time.
Exactly. Nifedipine, along with the other dihydropyridines, which typically share that ectopine suffix, by the way, like amlodipine or philodipina, they behave entirely differently.
They act predominantly on the peripheral vasculature.
Yes. They are highly targeted, aggressive, smooth muscle relaxers, making them significantly more potent peripheral vasodilators than verapamil or diltiazem. Crucially, though, nifedipine lacks significant clinical effects on AV conduction.
It completely ignores the heart's electrical wiring.
Right.
Which is wild because it's a calcium channel blocker, and the heart desperately needs calcium to conduct its electrical signals.
Right.
Yet nifedipine somehow bypasses that system and focuses almost exclusively on relaxing the blood vessels. How does it do that?
The clinical texts offer a really fascinating, deeply complex physiological explanation for this phenomenon. It involves an intracellular mechanism concerning an enzyme called phosphodiesterase.
Oh, man. When I first encountered the word phosphodiesterase in the literature, my immediate instinct was to skip over it and just pray it wasn't on the test.
I think every nursing student does that at some point.
But we promised to deliver the deep why today. So let's demystify this paradox.
Okay, it requires a bit of pharmacological gymnastics to conceptualize. We established that nifedipine blocks calcium at the surface membrane. But once the drug is in the system, it also inhibits this phosphodiesterase enzyme inside the cell.
Okay, inside the cell.
Yeah. And inhibiting this specific enzyme internally creates a bizarre biological contradiction.
Yeah.
It actually works to enhance calcium inflow at the surface.
Wait, what? The drug's internal action fights against its own inhibitory effects at the membrane level.
Exactly.
So the bouncer is blocking the front door, but somebody inside the club is actively trying to pull people in through the back windows. The drug is literally fighting itself.
That's a great way to put it. In the AV node of the heart, this internal enhancement mechanism essentially cancels out the surface blockade. The two opposing actions neutralize each other electrically.
That makes so much sense. That is the precise reason nifedipine does not slow down the heart's electrical conduction like verapamil does.
Right. However, in the vascular smooth muscle, so the tissue lining the blood vessels, this exact same phosphodiesterase inhibition results in additional relaxation.
It doubles down on relaxing the body's piping, but electrically cancels itself out inside the heart. The human body is just an endless series of brilliant, competing feedback loops.
It really is.
So, moving from the microscopic to the macroscopic, what does this massive vasodilation mean for the patient lying in the bed? Like, what therapeutic effects are we trying to achieve?
Well, the decrease in intracellular calcium physically prevents the contractile processes, right? So the muscle tissue loses its tone. This causes profound dilation of both the coronary arteries, the vital vessels supplying oxygenated blood directly to the heart muscle, and the systemic arteries running throughout the entire body.
Expanding the systemic arteries is like swapping out the body's plumbing. If you widen the diameter of a pipe, the pressure of the fluid flowing through it instantly drops.
Exactly. We see a massive decrease in total peripheral resistance, which translates clinically to a steep drop in systemic blood pressure.
And that drop in peripheral resistance heavily impacts a concept called afterload, right?
Yes, afterload is massive here. Afterload is the amount of physical resistance the left ventricle must overcome to force blood out of the aortic valve and into systemic circulation.
I always imagine trying to blow air through a tiny, narrow coffee stirrer versus blowing air through a wide industrial PVC pipe.
That's a perfect image. The coffee stirrer represents high afterload. It requires immense effort and strain. The PVC pipe represents low afterload, where the air just moves freely.
So nifedipine effectively transforms the body's arterial system from a network of coffee stirrers into a network of PVC pipes.
Which provides enormous life-saving relief for a struggling, overworked heart. The harder the left ventricle has to push against tight vessels, the more oxygen the heart muscle consumes to generate that force.
And this brings us to a monumental shift in how cardiovascular pharmacology is understood. Historically, didn't scientists believe these drugs primarily worked by improving oxygen supply?
Yeah, they thought it was all about dilating the coronary arteries to flood the heart tissue with more blood. But the modern clinical understanding recognizes a much more vital mechanism.
It is all about manipulating the systemic balance between oxygen supply and oxygen demand, right?
Exactly. By drastically reducing the afterload, nifedipine reduces the physical tension on the myocardial wall. The heart simply doesn't have to work as hard, which radically reduces its myocardial oxygen demand.
It's like a marathon runner sprinting up a steep hill. You could try to solve their exhaustion by forcing them to consume more oxygen and calories while they run, increasing the supply.
Right.
Or you could just magically flatten the hill. If they are running on flat ground, they don't need the extra oxygen anymore. Nifedipine flattens the hill.
I love that. And that dual action, increasing the supply of blood by opening coronary arteries, while simultaneously decreasing the demand for blood by lowering the afterload, perfectly dictates the clinical indications for the drug.
We use it to treat hypertension, obviously, because it rapidly drops blood pressure, and we also use it for chronic stable angina.
Right, angina being the severe, crushing chest pain a patient experiences when their heart muscle is starved of oxygen.
Usually because they are exerting themselves and the clogged coronary arteries just can't deliver enough blood to keep up with the work.
For chronic stable angina, the primary therapeutic benefit is that massive reduction in afterload. We are lowering the demand. But nifedipine has a highly unique indication for a specific condition called variant angina, which is frequently referred to as Prinzmetal's angina.
Oh, Prinzmetal's angina is a fascinating deviation from standard cardiovascular disease.
Yeah.
It isn't caused by cholesterol plaques slowly clogging an artery over decades, is it?
No, not at all.
Yeah.
It's caused by a sudden, violent spasm of the coronary artery itself. The vessel wall just clamps shut unpredictably, often while the patient is completely at rest.
It is entirely vasospastic. And because nifedipine is such an aggressive, potent relaxer of vascular smooth muscle, it's the perfect physiological weapon against these spasms.
Exactly. It essentially forces the spasming coronary arteries to relax and dilate, breaking the attack and instantly opening up the blood supply line to the starving heart tissue.
Okay, so we have clearly established that nifedipine is an absolute powerhouse when it comes to forcing blood vessels open. But understanding the sheer power of that vasodilation leads us directly into our next critical discussion.
Pharmacokinetics.
Yes. If a drug is this potent at dropping blood pressure, we have to meticulously control how it enters the patient's bloodstream. If we get the absorption math wrong, the patient's blood pressure doesn't just reach a healthy baseline. It plummets to a dangerous, shot-inducing low.
Right. How does this drug actually navigate the digestive tract and enter circulation? The journey of an oral medication through the body is governed by pharmacokinetics. And honestly, nifedipine's journey is incredibly hostile.
Hostile? How so?
Well, While it's very efficiently absorbed in the gastrointestinal tract, about 90% of the dose successfully crosses the gut wall, it immediately faces a brutal physiological gauntlet known as first-pass metabolism.
Ah, the first pass effect. This is a foundational concept that dictates dosing for countless medications. Whenever you swallow a pill, it dissolves and gets absorbed through the intestines, but that blood doesn't flow straight into your general circulation to reach your heart or your brain.
No, it takes a detour.
The venous drainage from the gut is shunted directly to the liver via the portal vein. The liver acts as the body's ultimate bouncer, to reuse our earlier analogy. It inspects, filters, and detoxifies everything coming in from the digestive tract before granting it access to the systemic circulation.
And the liver identifies the nifedipine molecules and immediately activates its enzymatic machinery to dismantle them. Because of this aggressive first-pass metabolism, only 50 to 70% of the original oral dose survives the liver's filtration to actually reach the systemic bloodstream.
And that surviving percentage is what we call the drug's bioavailability.
Exactly. The pharmaceutical engineers already know the liver is going to destroy roughly half the pill, so they design the dosage specifically to account for those heavy losses.
The specific metabolic machinery the liver uses to tear apart nifedipine is a vital enzyme pathway called CYP3A4, right?
The cytochrome P453A4. It's arguably one of the most important detoxification enzymes in human physiology, located primarily in the liver and the intestinal walls. Nifedipine is classified as a major CYP3A4 substrate.
Meaning it is the exact raw material this enzyme is built to break down?
You got it. The enzyme rapidly metabolizes the active drug into two completely inactive metabolites. These harmless byproducts are then filtered out by the kidneys and excreted primarily in the urine. Less than 5% of the original nifedipine dose is ever eliminated unchanged.
Wow, less than 5%. So because the enzymes are so efficient, the drug has a relatively short elimination half-life of roughly 2 to 5 hours.
Correct. We are operating on a very delicate physiological balance here. We administer a specific dose, fully relying on the CYP3A4 enzymes to destroy a predictable chunk of it.
If those enzymes are doing their job, the perfect amount of drug reaches the blood vessels. But what happens if something completely sabotages that enzyme pathway?
And this brings us to one of the most famous, heavily tested nursing implications in all of clinical pharmacology.
The grapefruit rule.
Yes, if you retain nothing else about drug-food interactions from this deep dive, burn this into your memory. The clinical guidelines are absolute. Patients must avoid grapefruit and grapefruit juice entirely before, during, or after drug administration.
To avoid potentially lethal increases in nifedipine bioavailability, we hear the no grapefruit juice rule constantly in nursing school, but I want to break down the actual mechanism. What is the juice doing? Is it highly acidic, causing the pill to dissolve too rapidly in the stomach?
Actually, it has absolutely nothing to do with stomach acid or gastric pH.
Early.
Yeah. Grapefruit, and specifically its juice, contains naturally occurring organic chemical compounds called frunocoumarins.
Frunocoumarins. Okay.
And these specific compounds have a profound affinity for the CYP3A4 enzymes, particularly those located in the mucosal lining of the intestinal wall. The frunocoumarins physically bind to the enzymes and permanently deactivate them.
Oh, wow. They don't just slow the enzymes down, they completely knock the detoxification machinery offline.
Exactly. The bouncer isn't just asleep. The bouncer has been removed from the building entirely. Because those intestinal enzymes are deactivated, they cannot perform the first-pass metabolism on the nifedipine as it gets absorbed.
So instead of 50% of the drug surviving, a massive, unmitigated wave of the active chemical floods directly into the systemic circulation.
Clinical studies demonstrate that co-administration with grapefruit juice increases the total drug exposure measured as the area under the curve and the peak plasma concentrations by a staggering twofold.
The twofold spike. The patient is suddenly hit with double the amount of active drug their body was expecting. And the literature specifies this happens without altering the drug's half-life.
Right. It doesn't stay in the body longer. It just peaks at an incredibly toxic level. This creates a highly dangerous clinical scenario. Imagine a patient who takes nifedipine every morning to manage their hypertension. One morning, they decide to wash their pill down with a large glass of grapefruit juice with their breakfast.
What's the immediate physiological consequence of that?
They are unknowingly administering a massive overdose of a potent peripheral vasodilator. The overwhelming volume of the drug hits those vascular calcium channels all at once.
Their systemic arteries relax so profoundly that their total peripheral resistance collapses.
And their blood pressure will plummet entirely out of a safe autoregulatory range. When they attempt to stand up from the breakfast table, their cardiovascular system won't be able to push blood up to their brain.
They'll experience severe, life-threatening hypotension, extreme dizziness, and they will likely lose consciousness and collapse, risking traumatic injury.
Exactly. The required nursing education here must be ironclad and uncompromising. You cannot simply advise the patient to avoid taking the pill at the exact same time as the juice.
Because the destruction of those enzymes by the furanocoumarins is so thorough that the body literally has to synthesize brand new enzymes to restore normal metabolic function, right?
Yes. That process can take hours, and sometimes days. The patient education must stress strict, total, categorical avoidance of all grapefruit products for the entire duration of their therapy.
Keeping with the theme of the liver acting as the vital gatekeeper for this medication, the clinical data also highlights a major caution regarding hepatic impairment.
Which makes perfect sense.
Right. If a patient has a history of severe liver disease, such as cirrhosis from alcohol abuse or chronic hepatitis, their liver tissue is severely scarred and its functional capacity is deeply compromised.
A compromised liver simply does not possess the necessary volume of functioning CYP3A4 enzymes to handle the standard first-pass metabolism. The clinical notes state that in the presence of hepatic impairment, the bioavailability of nifedipine is substantially increased, potentially reaching a 100% increase.
It's the exact same disastrous outcome as the grapefruit juice, but driven by organ failure instead of a food interaction. A standard safe dose instantly becomes a toxic dose because the liver cannot clear it.
Which means the nursing implication requires hypervigilance. Before administering this drug, the nurse must be actively reviewing the patient's chart, scrutinizing their liver function tests.
Looking at the AST, ALT, and bilirubin levels.
Right. If those markers are elevated, the nurse must anticipate that the standard dose is unsafe, and they may need to hold the medication and contact the provider to secure a significantly reduced dosage order.
It perfectly illustrates why understanding the metabolic pathway is non-negotiable. If you know the drug relies entirely on a healthy liver to be safely cleared from the body, your clinical intuition automatically tells you to be highly cautious the moment you see a diagnosis of liver failure.
Absolutely.
So we know the liver destroys half of the drug, and we know we need to maintain a steady level of vasodilation to keep the blood pressure controlled throughout the day. How do pharmaceutical companies engineer a physical pill to survive that metabolic gauntlet and deliver a consistent dose?
This transitions us perfectly into the rules of administration, the different formulations, and one of the most intense historical controversies in cardiovascular nursing practice.
I am so ready for this.
Nifedipine is manufactured in several distinct oral formulations, and the physical design of the pill entirely dictates the required nursing actions. We have immediate release capsules, frequently abbreviated as IR.
Okay, IR.
We also have sustained release or extended release tablets, often designated as SR or recognized by the brand name Adalat CC. Many of these utilize a highly specialized mechanism called a gastrointestinal therapeutic system, or GITs.
GITs. Immediate release operates exactly as the name implies. The capsule dissolves rapidly in the stomach, and the drug hits the systemic circulation fast.
The onset of hypotensive effects begins within 30 minutes to an hour, reaching peak effectiveness within 2 hours. Because it metabolizes quickly, the duration of action is only about 8 hours.
So a patient prescribed the IR formulation would likely be taking it multiple times throughout the day to maintain their blood pressure.
Correct. But the sustained release, the GITs formulation, this is an absolute marvel of biomedical engineering.
The GITs tablet is designed to solve the problem of fluctuating blood pressure by releasing nifedipine continuously in a zero-order process.
Yes. In pharmacology, zero-order kinetics means the drug is released at a constant, steady, unchanging rate over time, completely independent of how much drug is left in the pill.
It functions similarly to an intravenous drip, providing a smooth, continuous infusion of the medication into the gut, allowing for highly convenient once-daily dosing.
However, the physical mechanics of how this tiny pump operates leads to a very specific, frequently alarming patient education moment.
And this brings us right back to the scenario we opened the deep dive with, the ghost pill phenomenon.
We have to break down exactly how this pump works so the clinician can explain it to a panicked patient.
Okay, so the GI tablet is not a traditional pill that dissolves into powder. It is essentially a microscopic, rigid, plastic-like osmotic pump.
Right. During manufacturing, A tiny hole is precision drilled into one end of the tablet using a laser.
A laser-drilled hole. Got it.
When the patient swallows the tablet, it travels down into the watery environment of the gastrointestinal tract. The shell of the tablet absorbs water from the gut. As the water enters the shell, it creates internal osmotic pressure, which slowly and steadily pushes the active liquid drug out of that single laser-drilled hole over a 24-hour period.
That's amazing. But the outer shell of the tablet itself is entirely indigestible. It never dissolves.
Never. It maintains its exact physical shape throughout the entire digestive journey. Therefore, it is a physiological certainty that the patient will eventually go to the bathroom, look in the toilet, and see what appears to be a completely intact, unabsorbed pill sitting in their stool.
And their immediate reaction is panic. They hit the call light in their hospital room, or they frantically call the outpatient clinic insisting, "Nurse, my body is rejecting my medication. I just pooped out my blood pressure pill. It didn't work. I need to take another one right now."
And if the nurse isn't armed with the knowledge of the GIT's delivery system, they might agree with the patient and administer a second dose.
Which would lead to a catastrophic overdose.
Exactly. The informed nurse steps in with absolute confidence, calms the patient, and explains the ghost pill concept. You must educate the patient, precisely as the clinical guidelines dictate, that empty tablet shells in the stool are an expected, harmless outcome.
The active medication was successfully pumped out and absorbed into their body. They are merely passing the empty, plastic-like shell.
It is such a classically high-yield exam concept and a vital, real-world intervention.
What about the rules regarding food? We spent a lot of time on the dangers of grapefruit juice, but does standard food impact the absorption of these different formulations?
The rules vary slightly depending on the specific product. The manufacturer guidelines stipulate that Adalat CC should ideally be administered on an empty stomach.
Okay, empty stomach for Adalat CC.
Conversely, for other oral formulations, if the patient experiences significant gastric irritation or nausea, the medication can safely be administered with meals. Clinical data shows that the overall bioavailability of nifedipine does not appear to be significantly altered by standard non-grapefruit dietary intake.
Good to know. But there is one absolute unbreakable cardinal rule when handling the sustained release tablets.
It is the golden rule of pharmacology. Do not crush, break, or chew sustained release tablets under any circumstances.
Never. The logic is simple once you understand the engineering. If a patient or a nurse crushes an osmotic pump tablet, they violently destroy the delayed release mechanism.
By shattering that rigid shell, you are instantaneously converting a slow, 24-hour continuous dose into a massive immediate release dose. All 90 milligrams of the drug will be absorbed at once.
The patient will suffer a profound, immediate drop in blood pressure, potentially leading to cardiovascular collapse, ischemic stroke, or even death. The tablets must be swallowed entirely whole.
And this strict warning against physically altering the structure of the pill leads us directly into one of the most intense, heavily debated controversies in the history of cardiovascular nursing.
Oh, we need to talk about the sublingual controversy. Let me set the clinical scene to explain why this practice ever existed. You are working in a busy emergency department in the late 1990s.
Okay, painting the picture.
A patient is wheeled and experiencing a severe hypertensive crisis. Their blood pressure is terrifyingly high, let's say 210 over 120. They are complaining of a headache, and the physician is deeply concerned they are going to stroke out. The medical team wants that pressure brought down immediately.
And before modern guidelines were established, it was a very common, almost routine practice for a nurse to grab an immediate-release nifedipine liquid capsule, take an 18-gauge needle, manually poke a hole in the gel casing, and forcefully squeeze the liquid drug directly under the patient's tongue.
Wow. The physiological logic was that the sublingual mucosa is incredibly highly vascularized. We administer nitroglycerin under the tongue for instantaneous absorption directly into the systemic circulation to bypass the liver.
Right. The assumption was that sublingual nifedipine would bypass first-pass metabolism, absorb instantly, and crash the dangerous blood pressure down in minutes.
It sounds incredibly intuitive. It seems like smart, fast-acting clinical judgment. But our source material aggressively, unequivocally shuts this practice down. The literature states verbatim, sublingual administration of nifedipine has generated much controversy and confusion and is not recommended.
Why did the medical community completely reverse course on this?
Yeah, why?
The reversal happened because the perceived pharmacokinetic benefit was proven to be largely a myth, and the associated clinical risk was discovered to be astronomically high. Let's analyze the actual absorption data.
Let's do it.
The source clearly establishes that there is little difference in the relative bioavailability when immediate-release capsules are administered whole, bitten and swallowed, or bitten and held sublingually.
So sublingual administration offers absolutely no meaningful absorption advantage over simply swallowing the intact pill.
None. That shatters the entire premise right there.
The highly vascularized sublingual tissue isn't actually pulling the drug into the bloodstream any more effectively than the stomach and intestines.
No, it's not. The data shows that physically biting through the capsule to release the liquid does result in slightly earlier peak plasma concentrations. The drug hits the system approximately 10 minutes faster than if the patient swallowed an intact capsule.
But those 10 minutes of speed come at a terrifying, unacceptable physiological cost.
Because you are initiating an uncontrolled, highly unpredictable, and precipitously steep drop in blood pressure.
Exactly. The human body relies on a mechanism called cerebral autoregulation to maintain constant blood flow to the brain despite fluctuations in systemic blood pressure. If you drop a patient's blood pressure that violently and rapidly, you overwhelm the body's ability to autoregulate.
You severely compromise perfusion to vital organs. The brain and the heart require a certain threshold of hydrostatic pressure to physically push oxygenated blood through their capillary beds.
If the patient's mean arterial pressure crashes from 200 to 100 in the span of 10 minutes, the blood simply stops flowing adequately to those tissues.
You can instantly induce a massive ischemic watershed stroke or cause a myocardial infarction by starving the heart muscle of oxygen. The intervention meant to save them ends up causing the exact catastrophic event you were trying to prevent.
It is profoundly dangerous, which is why the practice has been entirely abandoned in modern medicine and is actively contraindicated. That is a phenomenal safety point that every clinician must understand. Do not poke holes in the capsules. Do not try to fast-track the drug. Just have the patient swallow the pill whole.
Agreed completely.
Before we transition away from administration rules, there is a very bizarre and highly specific dosage math trap regarding the Adalat CC formulation that the clinical notes highlight, and it screams, tricky NCLEX question.
Oh, this is a highly unique quirk directly related to the manufacturing geometry of Adalat CC specifically. The dosages are typically manufactured in 30 milligram, 60 milligram, and 90 milligram tablets.
Now, basic arithmetic would suggest that if a pharmacy is out of 60 milligram tablets, a nurse could safely administer 2 30 milligram tablets to achieve the exact same effect, correct?
Right, 30 plus 30 equals 60. And the manufacturer explicitly states that substitution is perfectly acceptable. 2 30 milligram Adalat CC tablets may be safely interchanged with 1 60 milligram tablet.
But here is where the math trap snaps shut. If a patient requires a 90 milligram dose, the nurse cannot administer 3 30 milligram tablets as a substitute.
No, they cannot.
But 30 times 3 is 90. It's the exact same total amount of medication. Why does the rule suddenly change?
It has to do with the physical geometry of the pills and how that impacts the zero-order release kinetics we discussed earlier. Let's visualize the physics of the gut. You have a single 90 milligram GITS tablet. It is a single sphere with a specific surface area exposed to the gastrointestinal fluids.
Okay, one large sphere.
The water seeps in through that surface area and pushes the 90 milligrams out of a single hole over 24 hours. Now replace that with 3 separate 30 milligram tablets. The total combined surface area of those 3 smaller spheres is significantly larger than the surface area of the single large sphere.
Oh, wow. Because there is vastly more surface area exposed to the gut fluids, more water is being drawn into the osmotic pumps simultaneously.
Precisely. The active drug is being forcefully pumped out of 3 separate laser drill holes at the exact same time. The total volume of drug release per hour skyrockets.
So the patient loses the safe, slow, 24-hour zero-order release, and instead they suffer a massive spike in blood levels, a substantially higher Cmax or peak plasma concentration.
Their cardiovascular system is hit with an overwhelming wave of vasodilation they weren't prescribed to handle. Therefore, 3 30 milligram tablets must never be considered interchangeable with a single 90 milligram tablet.
It is a prime example of why nursing requires a deep understanding of pharmacokinetics, not just basic arithmetic. Briefly, before we move into the side effects, the sources mention one highly unusual route of administration that I found fascinating: rectal compounding.
Yes, this represents an off-label clinical use. Off-label means the drug is not officially approved by the FDA for this specific route or indication, but it is utilized in practice based on clinical evidence.
Pharmacies will sometimes extemporaneously compound, which means they custom mix the ingredients on site, a 0.5% nifedipine rectal topical ointment.
The compounding notes specify diluting 100 milligrams of nifedipine into 20 grams of yellow soft paraffin, which is essentially yellow petroleum jelly. It is mixed with a spatula into a uniform ointment.
And the stability data notes it remains effective for about a year at room temperature, around 77 degrees Fahrenheit, if stored in an opaque container.
While it's a niche application, it's used topically in that region because its potent vasodilatory effects drastically increase local blood flow, which is highly effective in promoting the healing of painful conditions like anal fissures.
It's just a brilliant example of how versatile this drug's mechanism of action truly is.
The mechanism is undoubtedly versatile. However, that profound systemic vasodilation we have been analyzing from every angle, the body does not accept it without a fight. When you artificially force the body's vascular plumbing to expand, the cardiovascular system reacts aggressively.
Which perfectly transitions our deep dive into the next massive section, side effects and nursing management. Looking at the raw list of adverse reactions in the clinical source material is overwhelming. It is a mile long, categorized somewhat arbitrarily into mild, moderate, and severe.
But keeping our promise to apply the Pareto principle, we are not going to read a disconnected grocery list of symptoms. We're going to group the most common and the most dangerous side effects into logical, physiological buckets.
If you understand why they happen, you will automatically know what nursing assessments and interventions are required.
We must start with the most common, highly predictable bucket. These are the side effects that are a direct, logical, inescapable consequence of the drug doing exactly what it is supposed to do. We call this the vasodilation cascade.
We know nifedipine aggressively forces blood vessels to widen. What does that physical widening look like when manifested as a clinical symptom? Our sources show that dizziness occurs in an astonishingly high number of patients, up to 27%.
That's huge.
Right. Flushing, which presents as sudden, intense redness and warmth of the skin, occurs in up to 25%. Throbbing headaches are reported in up to 23%.
Every single one of those symptoms is directly tied to the widening of the body's pipes. When the millions of tiny blood vessels just beneath the skin dilate, a massive volume of warm, oxygenated blood flows near the surface, causing that visible red flushing and feeling of heat.
And when the blood vessels inside the brain dilate, the increased blood volume slightly elevates intracranial pressure, physically stretching the sensitive pain receptors surrounding the vessels, resulting in that classic relentless throbbing headache.
Exactly. And when systemic pressure drops across the entire body, the cardiovascular system struggles momentarily to push blood against gravity when the patient stands up. That momentary drop in cerebral perfusion is what causes the profound dizziness.
Then there's one very specific, highly common moderate side effect that requires deep understanding: peripheral edema. Significant swelling of the lower extremities occurring in 4 to 30% of patients. Understanding the exact mechanics of why this fluid pooling happens dictates the entirety of the nursing assessment.
The peripheral edema induced by calcium channel blockers is driven by a fascinating asymmetrical pathophysiological mechanism. Nifedipine preferentially dilates the arterioles.
Arterioles are the small, highly muscular arteries that carry high-pressure blood into the capillary beds. Because they have thick layers of smooth muscle, nifedipine relaxes them profoundly, opening the floodgates.
However, the drug does not have the same dramatic effect on the venules. Venules are the thin-walled veins responsible for carrying the blood away from the capillary beds. They lack that thick muscular layer, so they don't dilate significantly.
You essentially create a massive physiological traffic jam. You have a massive 8-lane highway of blood rushing into the capillary beds, but only a small 2-lane country road available for the blood to exit.
That asymmetry creates an intense bottleneck. The volume of blood entering the capillaries vastly exceeds the volume that can exit. This causes a massive spike in capillary hydrostatic pressure, the physical force of the fluid pushing against the fragile capillary walls.
The fluid has nowhere to go but out. It is physically forced through the microscopic gaps in the endothelial lining, escaping the vascular space and flooding into the surrounding interstitial tissues.
Because of gravity, this escaped fluid invariably pools in the lowest points of the body, presenting as pronounced swelling in the ankles and lower legs.
Armed with this understanding of the vasodilation cascade, how does the nurse manage the patient? What are the concrete interventions?
First and foremost, meticulous vital sign monitoring. You are tracking blood pressure constantly, specifically assessing for orthostatic hypotension, the dangerous drop in pressure when transitioning from lying down to standing.
You must rigorously teach the patient fall precautions. The education should be explicit. When you wake up, do not simply stand up. You must sit on the edge of the bed with your feet dangling for a full 60 seconds to allow your blood pressure to equalize before you attempt to walk.
For the severe headaches, you anticipate an order for a mild analgesic, and you reassure the patient that these vasodilation headaches frequently diminish over time as the body's vascular system acclimates to the drug.
And for that peripheral edema, your assessment is hands-on. You are physically assessing the lower extremities daily. You are pressing into the tissue to check for pitting edema, grading the severity of the swelling.
You advise the patient to elevate their legs above the level of their heart whenever they are sitting down, utilizing gravity to help drain that interstitial fluid back into central circulation. You might also anticipate a provider order for compression stockings to physically squeeze the fluid back into the vessels.
But here's the most critical nursing distinction to make regarding edema. You must be able to clinically differentiate between this expected, benign, vasodilation-induced peripheral edema and the highly dangerous edema caused by worsening heart failure.
Which serves as a perfect segue into our next physiological bucket of side effects, the cardiac paradox. Nifedipine is prescribed to assist and relieve the heart, yet under certain conditions, it can violently agitate it.
The moderate and severe adverse reactions list includes palpitations occurring in up to 7% of patients, sinus tachycardia, a racing heart rate bradycardia, severe exacerbation of heart failure, and even myocardial infarction.
Let's unpack the racing heart rate first.
Why would a medication specifically designed to lower blood pressure cause the heart to accelerate wildly?
The acceleration is not caused by the drug acting directly on the heart. It is a sympathetic nervous system reflex fighting against the drug. When nifedipine induces that rapid, massive peripheral vasodilation, the systemic blood pressure plummets.
The human body is equipped with baroreceptors, highly sensitive pressure sensors located strategically in the carotid arteries and the aortic arch. These sensors detect the sudden, precipitous drop in pressure.
They interpret this drop as a catastrophic emergency, akin to massive blood loss. They send an urgent distress signal to the brainstem screaming, "We are losing pressure. We're going to lose perfusion to the brow and we must compensate immediately."
The brain responds by activating the fight-or-flight response. It dumps massive amounts of adrenaline and noradrenaline into the system. It fires up the sympathetic nervous system to force the heart to beat significantly faster and squeeze harder, desperately trying to pump more blood volume to force the pressure back up to baseline.
That phenomenon is clinically defined as reflex tachycardia. The patient physically feels this as palpitations, an uncomfortable fluttering or racing sensation in their chest.
Now, earlier in our discussion, we established that nifedipine rarely exhibits negative inotropic effects in a clinical setting, meaning it rarely weakens the physical squeezing force of the heart muscle despite blocking calcium.
This profound reflex tachycardia is precisely the reason why. The body's panicked, adrenaline-fueled reflex to speed up and squeeze harder essentially overrides and masks any direct calcium-blocking weakening effect the drug might have had on the myocardium.
While that reflex keeps the blood pumping, it is incredibly dangerous for specific patients. If a patient already suffers from severe coronary artery disease, their vessels are clogged with plaque. They cannot deliver extra blood to the heart muscle.
If their brain suddenly orders their damaged heart to sprint at 130 beats per minute, the heart muscle will instantly exhaust its oxygen supply. That drug-induced reflex tachycardia can directly provoke a severe angina attack.
Or in worst-case scenarios, as the clinical warnings emphasize, it can induce a full myocardial infarction. The drug inadvertently causes a heart attack by forcing the heart to overwork.
This physiological tug-of-war is exactly why continuous cardiac monitoring is frequently initiated during the initial titration phase of dosing, particularly in vulnerable cardiac patients.
The nurse is constantly watching the telemetry monitor for dangerous tachycardia, premature ventricular contractions, or any ST segment changes indicating active cardiac ischemia.
What about the profound risk of exacerbating heart failure?
As we explored, lowering afterload generally provides immense relief to a failing heart. It makes pumping easier. However, in patients diagnosed with severe, pre-existing, decreased left ventricular function, meaning their heart is already barely squeezing, their hemodynamic balance is incredibly fragile.
Any sudden disruption to that delicate equilibrium, whether through massive fluid volume shifts caused by the vasodilation or minor alterations in contractility, can overwhelm the damaged ventricle and send them into acute decompensated heart failure.
Therefore, the nursing management for the heart failure risk heavily overlaps with our edema assessments. You are weighing the patient strictly every single morning at the same time, on the same scale. If the patient gains 3 pounds in a single day or 5 pounds in a week, you do not simply write it off as the benign capillary pooling we discussed earlier.
You must escalate your assessment. You grab your stethoscope. You auscultate the lung field, specifically listening for crackles or rales. You inspect the patient's neck for jugular venous distension.
You are actively searching for signs that the fluid isn't just pooling in their ankles, but is physically backing up into their lungs because their weakened heart is failing to pump it forward.
It is about synthesizing multiple clinical data points. Ankle edema, combined with perfectly clear lungs, usually points to the benign vasodilation side effect. Ankle edema, combined with pulmonary crackles, rapid weight gain, and shortness of breath strongly indicates a life-threatening heart failure exacerbation.
Let's examine the final bucket of side effects: the severe or potentially fatal dermatological and gastrointestinal dangers. These reactions are incredibly rare, but when they occur, the nurse's rapid intervention is the only thing standing between the patient and death.
The clinical literature lists exfoliative dermatitis, Stevens-Johnson syndrome, commonly known as SJS, and toxic epidermal necrolysis, or TEN-AN.
The exact incidence rates are unknown because they are so statistically rare, but they are absolutely devastating. SJS and TEN are not standard drug side effects. They are catastrophic hypersensitivity immune reactions.
For unknown reasons, the patient's immune system reacts to the presence of the drug molecule by violently attacking the body's own skin and mucous membranes.
The reaction insidiously begins with vague flu-like symptoms: fever, fatigue, sore throat. This is rapidly followed by the eruption of a painful red or purplish rash that aggressively spreads and forms large blisters.
In the final horrifying stages, the top layer of the epidermis detaches and literally dies and sheds off the body in massive sheets.
From a critical care perspective, you are essentially treating the patient like a severe burn victim because they have entirely lost their protective skin barrier, leaving them completely vulnerable to massive fluid loss and overwhelming sepsis. The mortality rate is terrifyingly high.
The nursing implication here is absolute and black and white: immediate, permanent cessation of the offending drug.
The patient education must be explicitly clear. If you develop any unusual rash, any blistering, any unexplained skin peeling, or any painful sores inside your mouth or on your lips, you must stop taking this medication instantly and go directly to the nearest emergency room. You cannot advise them to wait and see if it clears up with an over-the-counter cream.
Looking at the severe gastrointestinal side effects, the literature includes severe GI bleeding, peptic ulcers, dangerous GI obstructions, and the formation of a bezoar.
A bezoar.
A bezoar is a tightly packed, solid mass of indigestible material that slowly accumulates within the digestive tract, eventually creating a physical, impenetrable blockage. This complication is often directly related to the sustained release formulations.
Oh, because the drug can alter gastrointestinal transit times, slowing everything down, and the physical indigestible shells of the GIT's tablets can coalesce and contribute to a mass, particularly in patients who already suffer from compromised gut motility or previous bowel surgeries.
Exactly. The risk of a severe GI bleed requires highly specific patient education. You are instructing the patient to closely monitor their bowel movements. You aren't just telling them to look for the harmless ghost pill. You are explicitly warning them to look for melena, dark, black, tarry, incredibly foul-smelling stools that are the hallmark sign of digested blood originating from an upper GI bleed.
In the hospital setting, the nurse is vigilantly monitoring the patient's complete blood count, watching for unexplained drops in hemoglobin and hematocrit levels that would indicate internal bleeding.
The overarching, unifying theme of nursing management for nifedipine is continuous hypervigilance. The clinician is constantly balancing the management of the predictable common issues, fluid pooling and blood pressure drops, while keeping their clinical radar actively scanning for the rare but catastrophic immune, cardiac, and gastrointestinal complications.
Managing these complex physiological variables in a standard adult patient requires immense skill. But the clinical stakes rise exponentially, and the medical decisions become infinitely more complex and ethically fraught when we enter the realm of special populations. The clinical math becomes terrifying when you're treating 2 patients inside one body. Let's delve into the use of nifedipine during pregnancy and lactation.
This specific clinical area is where the nurse transitions from merely administering medication to acting as a vital patient advocate and high-level educator. The nurse must help the frightened patient navigate an incredibly difficult, deeply nuanced risk versus benefit calculation. Let's examine the pregnancy data first.
The source material is remarkably blunt regarding human data. It states, there are no adequate and well-controlled studies of nifedipine use in pregnant women, which, from a medical ethics standpoint, is entirely understandable. You cannot ethically design a randomized controlled trial where you administer potentially dangerous experimental pharmacological agents to a cohort of pregnant women just to see what happens to their unborn children.
So in the absence of human trials, what data do the providers base their decisions on? They rely heavily on in vivo animal data, and the animal reproduction studies are profoundly concerning. Across multiple studies involving pregnant rats, mice, and rabbits, nifedipine has been proven to be aggressively teratogenic.
Teratogenic meaning the chemical actively causes severe physical malformations and developmental disruptions in the growing embryo or fetus. The specific deformities documented in our clinical sources are grim. The drug caused stunted fetal growth, high rates of embryonic deaths, and fetal deaths.
In pregnant mice, it induced severe rib deformities and cleft palates. In primate studies involving monkeys, the administration of nifedipine resulted in abnormally small placentas and severely underdeveloped chorionic villi. The chorionic villi are the microscopic vascular projections vital for facilitating the exchange of oxygen, blood, and nutrients between the mother's circulation and the baby's.
Furthermore, in rat studies, the drug caused abnormally prolonged pregnancies and significantly decreased neonatal survival rates after birth. The scientific consensus is clear. Nifedipine aggressively disrupts fundamental fetal development, bone formation, and placental vascular health in mammalian models.
Yet, that horrifying list of developmental catastrophes, why isn't this drug slapped with an absolute 100% never use under any circumstances black box contraindication for pregnant women?
Because of the harsh clinical reality of severe maternal hypertension. If a pregnant woman develops dangerously high blood pressure, such as severe preeclampsia or a sudden hypertensive crisis, that untreated hypertension is imminently life-threatening to both the mother and the fetus.
A maternal blood pressure of 200 over 120 can cause the mother to suffer a massive hemorrhagic stroke. It can cause placental abruption, where the placenta violently tears away from the uterine wall, resulting in massive internal bleeding and immediate fetal death.
The medical team is trapped in a horrific clinical catch-22.
Exactly. The official clinical guideline, meticulously worded in the source text, dictates that nifedipine should only be utilized during pregnancy if the potential life-saving benefit to the mother clearly justifies the unknown, potentially devastating risk to the fetus.
If the mother's uncontrollable blood pressure is guaranteed to kick them both within hours, the physician may be forced to utilize nifedipine to save the mother's life, forcing them to accept the teratogenic risks to the baby. It is classified as a relative contraindication, heavily dependent on the desperation of the specific clinical scenario.
The nurse's role in that high-stakes scenario is multifaceted. They must provide immense emotional support to a terrified mother, facilitate clear, honest communication regarding the risks, and execute rigorous, constant monitoring of both maternal blood pressure and continuous fetal heart rate tracing to detect any signs of fetal distress the moment the drug is administered.
But what happens after the baby is successfully delivered? Let's transition to the complexities of lactation and breastfeeding.
Here, the clinical guidelines present a fascinating, deeply confusing contradiction in the medical literature, and it is the nurse's responsibility to help the mother make an informed choice. Nifedipine is a highly lipophilic drug, meaning it distributes easily into fatty tissues, and it is known to excrete into human breast milk.
Because the chemical is definitively present in the milk, the pharmaceutical manufacturer takes a highly defensive, unyielding stance. The clinical source states, the manufacturer does not recommend breastfeeding during nifedipine therapy. They are legally protecting themselves from any potential liability.
However, when you consult the leading pediatric authorities, the guidance completely flips. The source literature notes that previous, highly influential recommendations from the American Academy of Pediatrics, the AAP, actually classified nifedipine as usually compatible with breastfeeding.
That conflicting information is incredibly maddening for a new mother. The company that makes the drug says absolutely not, while the nation's leading pediatricians say it's generally fine. How does a clinician synthesize that contradiction to advise a patient safely?
We must look past the blanket statements and analyze actual pharmacokinetics of the milk transfer. combined with the specific physiology of the newborn. The clinical data we have is incredibly sparse, based largely on data extracted from a single mother-infant pair.
Based on that limited observation, it is estimated that the total amount of active drug that successfully transfers into the breast milk and is ingested by the infant is less than 5% of the mother's total therapeutic dose.
5% sounds like a microscopic, clinically insignificant amount. Why is the manufacturer so terrified of a 5% exposure?
Because of the unique, extreme vulnerability of the infant's cardiovascular system, adult hearts have a well-developed internal cellular structure called the sarcoplasmic reticulum, which stores a massive reserve of calcium.
If an adult takes a calcium channel blocker, their heart has internal backups to keep beating. A neonatal myocardium, the heart muscle of a newborn, is deeply underdeveloped. It does not possess an adequate sarcoplasmic reticulum. It lacks an internal calcium reserve.
Therefore, a newborn's heart relies almost entirely on the continuous transmembrane influx of extracellular calcium with every single heartbeat to maintain its contractility.
So a neonatal heart is hypersensitive to any disruption in calcium flow.
Profoundly hypersensitive. Even a microscopic 5% dose of a potent calcium channel blocker could potentially disrupt the delicate, precarious calcium balance required for a newborn's heart to beat effectively. We simply do not possess the clinical data to know what a safe dose of nifedipine is for a 3-day-old infant.
The physiological danger isn't that the baby is receiving a massive adult dose. It's that even a microscopic trace amount might be enough to shut down the hypersensitive contractile trigger in their developing heart.
Yeah.
Given this terrifying biological reality, what is the concrete nursing management? What exactly do we advise the mother who absolutely must continue taking nifedipine to survive her postpartum hypertension, but who desperately, emotionally needs to breastfeed her child?
We utilize our deep understanding of pharmacokinetics to engineer a safety window. We know the drug reaches its peak concentration rapidly and clears from the system relatively quickly, possessing a half-life of roughly 2 to 5 hours. Therefore, clinical researchers concluded that the mother can employ a timing strategy.
We advise the mother to delay breastfeeding or to actively express and discard her breast milk for 3 to 4 hours after she swallows her dose. By waiting out that critical window, the mother allows the drug concentration in her blood plasma and subsequently her breast milk to plummet significantly, drastically reducing the total amount of active drug the nursing infant is exposed to.
It is an exhaustingly meticulous scheduling strategy. You take the pill, you pump and dump the milk for 4 hours while the drug concentration is at its toxic peak, and then you safely resume direct feeding once the chemical levels have dropped off. It requires intense dedication from the mother, but it allows her to safely provide the immense immunological benefits of breast milk while managing her disease.
You're constantly weighing competing variables, the profound health benefits of breastfeeding, the theoretical cardiac risk of infant drug exposure, and the immediate lethal risk of the mother's untreated severe hypertension. But before we conclude our discussion on lactation, there is one highly surprising, deeply paradoxical off-label use for nifedipine mentioned in the clinical sources that demands attention.
Nifedipine is actively utilized off-label to treat a severely painful condition known as Raynaud's phenomenon of the nipple.
Raynaud's phenomenon is a vascular disorder typically associated with the fingers and toes. It involves an intense, highly painful episodic vasospasm of the microscopic blood vessels, usually triggered by cold temperatures or emotional stress. The spasms violently cut off blood flow, turning the digits stark white, then blue from lack of oxygen, and finally burning red as the blood rushes back in.
But this exact same violent vasospasm can occur in the highly vascularized tissue of the nipples in breastfeeding mothers. The microscopic blood vessels spasm uncontrollably, causing excruciating, stabbing pain during or immediately following a feeding session. Because we know nifedipine is the ultimate, unrivaled relaxer of vascular smooth muscle, our unmoving nightclub bouncer, it is incredibly effective at forcing those microscopic vessels in the nipple to forcibly dilate, instantly restoring vital blood flow and eliminating the agonizing pain.
Which creates a truly fascinating high-wire paradox for the managing nurse. You are actively administering a medication that we know passes into breast milk, which we know carries theoretical, poorly understood cardiac risks to the developing infant, specifically to treat a localized pain condition that is physically preventing the mother from breastfeeding. It represents the ultimate tightrope walk of clinical judgment and risk assessment.
It perfectly illustrates the reality that clinical nursing is never simply reading a warning label and following an algorithm. It requires applying immensely complex, often contradictory scientific data to messy, real-world human scenarios. Take a deep breath. We have covered a truly massive expanse of pharmacological and physiological ground today. We journeyed from the microscopic voltage-gated calcium pores on a single smooth muscle cell to the massive fluid dynamics of systemic vascular resistance. We navigated the liver's ruthless enzymatic assembly lines, decoded the engineering of osmotic pumps, and wrestled with the intense ethical dilemmas of the maternity ward. It's time to land the plane. Let's synthesize all of these complex, interwoven elements for our final outro and deliver the 80-20 summary.
If you are walking into a high-stakes pharmacology exam tomorrow morning, or stepping onto a cardiac unit for a shift, these are the absolute highest yield concepts you must have permanently locked into your clinical memory.
Number 1. The mechanism of action. Nifedipine is the prototype dihydropyridine calcium channel blocker. It physically barricades the calcium pores on vascular, smooth muscle, preventing contraction. It absolutely does not alter serum calcium levels. It acts almost exclusively on the peripheral vasculature, causing massive vasodilation. This dilation significantly decreases total peripheral resistance, which dramatically decreases afterload. This action simultaneously lowers systemic blood pressure and radically reduces the heart's myocardial oxygen demand.
Number 2. The grapefruit rule. Nifedipine is a major CYP3A4 substrate subject to heavy, ruthless first-pass metabolism in the liver and gut. The compounds in grapefruit juice physically bind to and destroy these specific intestinal enzymes, leading to a highly dangerous, unpredictable, twofold spike in active drug concentration in the bloodstream. Strict categorical avoidance of all grapefruit products is a non-negotiable patient education requirement.
Number 3. Administration rules. You must proactively warn the patient about the harmless ghost pill phenomenon in their stool when prescribed GIT's formulations to prevent panic and accidental overdosing. You must never crush, break, or chew sustained-release tablets, as it will induce a lethal overdose. And remember, the absolute clinical ban on the sublingual administration of liquid capsules for hypertensive emergencies due to the catastrophic risk of overriding cerebral autoregulation and inducing massive ischemic strokes.
Number 4. Side effects and nursing assessment. You must anticipate the highly common vasodilation cascade: dizziness, severe flushing, throbbing headaches, and pronounced peripheral edema caused by capillary hydrostatic pressure pooling in the venules. Crucially, the nurse must be able to clinically differentiate this expected benign fluid pooling from the highly dangerous edema associated with heart failure exacerbations by meticulously assessing daily weights and auscultating the lungs for crackles.
And finally, you must monitor continuously for reflex tachycardia. This occurs when the body's baroreceptors panic over the sudden, drug-induced drop in blood pressure and command the sympathetic nervous system to violently speed up the heart rate. Which brings us to our final, parting thought. We always want to leave you with a complex physiological concept to mull over on your own, something that builds upon the foundation we've established today and pushes your critical thinking to the next level. We spent a significant amount of time detailing how Nifedipine Brilliant reduces myocardial oxygen demand by radically lowering the afterload, by widening the systemic pipes so the damaged heart doesn't have to push as hard against resistance.
But we also spent considerable time analyzing that highly dangerous, predictable side effect: reflex tachycardia. The sympathetic nervous system forcing the heart to beat significantly faster and squeeze much harder to desperately compensate for that exact same drop in pressure. Here's a provocative physiological question I want you to explore. If artificially lowering the afterload inherently decreases the heart's oxygen demand, but the resulting reflex tachycardia inherently increases the heart's oxygen demand by forcing the muscle to sprint, how does that violent biological tug-of-war actually play out inside the chest of a patient who already suffers from critical, severe blockages in their coronary arteries? Does the immense relief provided by the widened pipes outweigh the extreme danger of the racing adrenaline-fueled heart? Or does that racing heart rapidly consume all available oxygen, leading to devastating ischemia regardless of the lowered resistance? It is a profoundly complex question of hemodynamic balance, and mastering that specific push and pull relationship will elevate your clinical reasoning from that of a student to that of a true expert.
Thank you for sitting in the third chair with us today and tackling one of the most notoriously dense, multifaceted pharmacological profiles in cardiovascular medicine. You came out the other side armed with the deep, unshakable why behind the clinical facts. You have moved far beyond rote memorization. You are building a functional, predictive understanding of human physiology. Trust your preparation. Best of luck on your upcoming exams and clinical rotations, and we will see you on the next deep dive.